Um, so I'm going to hand over to Nombuso Madonsela, who will be facilitating the next panel discussion. And she will be joined by Rashad Amra, who is a health economist, and Jonathan Davin, who is with the National Treasury, and will be focusing on understanding health financing landscape and its options. Over to you.
Thank you very much, and welcome back to everyone. Before we start on our next section, I just want to acknowledge the last speaker. I think she spoke a lot about what are the gaps with regards to cancer management within our health system. I mean, currently they've got a court case fighting for the rights of the individuals, like was mentioned earlier, and we understand that part of primary prevention really needs to start within the primary healthcare setting. So it actually fits in with what we are speaking about, to say we need to have the finances within our primary health, redirected to our primary health care, so that we can be able to screen. The policies are there, and she really articulated there's clear policies, but it also leverages on the discussion that was had in the earlier session to say, in the community's framework, our community also needs to be educated. Some of these languages or the terminology that we use as what is we're calling, they say we are clever blacks, becomes very important if we want to communicate to the community on the importance of screening. And if we do early screening, we are able to alleviate progression of cancer to the levels that they are in. It is a very expensive management because it's managed at a tertiary level, but there are different steps which could be circumvented to ensure that we do early screening. In my training, I will never forget, we went to Mankweng in Limpopo. Even now, I can tell you where that cervical cancer ward is. I can be able to imagine the smell and the despair of the clients that were in that particular ward. It remains ingrained in my memory. So cancer, as she has spoken, is the second biggest disease that we need to acknowledge, and we need to be able to have a shift within not only the policy, because I think the policy makers have made sure that there are clear guidelines, is the implementation and also the funding, and making sure that it also becomes one of those conditions that will be taken very seriously, like the South African, I mean, like the HIV and TB. And I really think from the speaker, we acknowledge that we need to have a South African cancer a society that is looking at ensuring that this proper management is happening. So let us then continue with our program today. We will allow the next speaker. I introduce him correctly. It will be Mr. Rashid Amra, who's a health economist, who's going to speak about understanding the fiscal space South Africa finds itself in the current period. We've just had the budget speech. We've had concessions from the minister to say there's allocation of budget, and let us see where we are and how much of that budget that has been tabled is assigned to the health system. So with that, can I allow you to come through?
Okay, good morning, everybody. Nice to see everybody here today. I initially came in this morning without slides, and an economist without slides is like a one-handed economist. He'll give you a correct answer. So let's proceed. I have some introductory remarks based on last week's speech, but it's more fiscal history to frame where we were last week. And the short answer is there isn't any fiscal space. But I'll elaborate upon that. So if we proceed with the slides, thank you. Okay, so 2008 is kind of like where our fiscal history begins. 2008, we had a financial crisis. We had a significant increase in spending post 2008, but it really accelerates where some people call it the Polokwane moment, if you remember ANC conferences. So we have a growing gap between revenue and expenditure, which the late Tito Mboweni used to call the hippo. He always wanted to close the gap between revenue and expenditure. So this is kind of what happens with the financial crisis. We increase spending, we loosen the purse strings in certain respects to respond to slowing growth and increasing needs for the economy. But for revenue to grow, revenue is in blue over here, you need growth. Growth has been rather anemic in that period for the past 15 plus years. And so you see a growing gap between revenue and expenditure. Now, when your revenue is less than your expenditure, you need to borrow. Next slide. And so when you borrow, you're running budget deficits. You're borrowing according to your needs. And this is, if it's on the black line over here, you're balancing your budget, so to speak. What's very important to note over here is the primary balance. That's the difference between the revenue you collect and your non-interest expenditure. And so for some time, we were running deficits. This big drop over here, as you know, will be the COVID time where growth slowed, but we also had to increase expenditure. And so we've been running budget deficits for a long time, and the effect of that is increasing debt now. Debt around 2008, at the time of the global financial crisis, was about 24%. It's increased precipitously to 2025, around 76%. Now, when you're increasing your debt, you have to issue debt when your revenue is exceeded by your expenditure. Next slide, please. You have to service that debt, so you have to pay interest on that. Now, debt is not a problem. Borrowing is not a problem. We have social needs. A country with such high levels of inequality and deprivation, we have to spend. But when you spend and you borrow, you have to service that debt. So in the year 2008, 76 billion rands went to servicing our debt. Last year, or the current financial year that's about to conclude, 420 billion rands goes towards servicing that debt. So the question for the Minister of Finance responsible for balancing or maintaining a healthy public balance sheets and public finances is how does he, or maybe in the future we'll have a female Minister of Finance, she manage the needs of society with managing our debt stock and is it justifiable that we spend 420 billion rands and sustainable 420 billion rands to service our debt, knowing that 420 billion rands could be allocated to something more useful, right? So public provision of goods. And to do that, you have to slow down your growth in your debt. So enter the period of fiscal consolidation. That is a fancy way of saying we want debt to stabilize the share of GDP. In the previous graph, you saw debt continuously increasing. The stated objective for the past 10 years plus has been to stabilize debt as a share of GDP. How do you do that? You need to reduce your deficits. I showed you those growing deficits over time. And to do that, you either have to increase revenue, decrease expenditure, or both, or a combination of the above. So government has been trying a combination of the above. I would say more biased towards slowing expenditure growth. And that's been the case over the past 10 to 15 years, is slowing expenditure growth. Government has attempted to increase revenue through a increase in the VAT rate. Previously, last year's one didn't really work out too well for government. And slowing expenditure growth. The impact of this, and we've seen it in health, in education, in social protection, in policing, has been that the provision of public goods, the quality of it has deteriorated over time. Without a major refixing or reconfiguration of your service delivery model, slowing the expenditure growth means in per capita terms, the allocation actually slows or decreases once you account for inflation. And this has been fiscal consolidation. The path government has very vehemently, dog-headedly pursued with justifiable objectives, but really deleterious effects on the provision of public goods. So this has been the case, And government keeps on saying that next year public debt as a share of GDP is going to stabilize, meaning not increase. And this has been the promise for the past 5 years. Finally, in this year's budget, we actually have a credible path, a credible outlook for debt as a share of GDP. This is in part because we're seeing strong performance in terms of revenue last year, and the growth of the South African economy is not as bad as it was. We had 4 quarters of consecutive growth. So government, and this is quite credible in my estimation, or our estimation, that debt will stabilize the share of GDP. And so maybe we breathe a sigh of relief. Debt as a share of GDP is about to stabilize. Does that mean we have more fiscal space to continue spending on health, on social provision of social grants, policing, and education? No, government has changed the fiscal objective from consolidation to debt reduction. And this, I haven't seen much narrative in the public on this. Now, this means the implication of this, and this needs to be contested quite strongly in Parliament, whilst the objective is understandable, important, and necessary for the economy, the implication of this change in fiscal objective is that budgets are going to be constrained for the next 7 years for them to realize this debt as a share of GDP. So we thought we're going to have a plateauing of debt as a share of GDP, but no, government wants to reduce or has proposed a reduction in debt as a share of GDP over the medium term. The short implication is that stronger primary surpluses, meaning revenue less non-interest expenditure, needs to be even larger for us to realize that path over the medium term. The implication of that, despite there being a 4.3% increase in the allocation for health this year, which is stronger than other line departments and other services, is that this is we're not going to be finding much space for provision to grow faster than inflation and population growth. So that's the short context of the 2026 budget. One anecdote is we never had any increase above inflation to what we colloquially refer to as the sin taxes, that mean alcohol consumption and smoking. And the outlook, therefore, is one where there isn't much space. Sorry, are we okay? And that's kind of my contextual slides, and we'll like to move on to the conversation.
Can we request MN to mute, please? Thanks. Thank you very much. I think in summary, is there a hand?
It's not.
Oh, you have been able to mute? Okay, thank you very much. Thank you for explaining it in a layman's term that we are still in debt. And the 420 billion was extraneous for me. But we're in the right path to try and reduce the debt, but we must find extra revenue streams in order to be able to ensure that we continue servicing the population with health, policing, and every other strategies that we have. Okay, then can we then take the next speaker? It will be Mr. Van Heerden. Okay, Mr. Jonathan David. He's going to give us perspectives on financing the district health response. So hopefully, once we have the revenue up and we minimize the debt, then we can use the funds that we will have to be able to facilitate financing the districts that we are currently implementing the health system. Thank you. Over to you.
Thank you very much, and good morning, right? Yes, good morning, everyone. My name is Jonathan Daven. I'm from the National Treasury. I work in the Public Finance Division, so responsible for budgets, specifically health budgets is what I focus on in my work. I'll present a little bit on kind of contextualizing district health spending specifically. What are some of the trends? What are some of the challenges that we identify when looking at those trends and patterns? So we can move to the next slide, please. So this slide shows the share of total health spending across the 8 different budget programs in the provincial departments of health. So you see this line here is the district health services. So district health services has always been the largest share of provincial health budgets. And it has been increasing over time. So this is, as I said, it's a percentage of total. So an increase here does not necessarily mean, in many cases, it is an increase in RAND terms, but not necessarily. It's just it shows as a percentage of total. A lot of this has been driven by HIV because there's been additions to the HIV conditional grants over time to fund the rollout of ARV treatment. We can move to the next slide. So within that district health services program, which was the top line that I showed you, this is the sub-programs. So it has quite a few different sub-programs. As you see, the largest one would be district hospitals right here. So out of the 124 billion spent on district health services in 23-24, 41 billion was spent on district hospitals. The second biggest one, which is the one that has been growing quite a bit, especially looking at a longer period, is HIV/AIDS, which is 25 billion. And we can move to the next slide. So this shows the district health spending per capita, and it's converted to real prices, which means that you strip out inflation from this. So it adjusts for inflation, and it's divided, the spending divided by the uninsured population. So we're not including the medical scheme beneficiaries in this. And as you can see, it has increased for quite some time. And if you would have dragged out this figure to even longer period of time, you would see that it has actually more than doubled, say, over the past 15, 20 years. So it has seen quite a strong increase over time. But since COVID, which we saw in the earlier slide, where, you know, expenditure increased rapidly, whereas the economy saw some major challenges and which had impact on revenue. Government has had to reduce its overall expenditure quite significantly, and that has had an impact on health spending as well. So this shows that in more recent years, so from the peak of COVID in 2021-22, district health services spending per capita in real terms has decreased. We can move to the next slide. So how do the different provinces compare in terms of district health spending? You see that there's quite a big variation, ranging from Gauteng, which spends about 1,800 Rand per capita on district health services, to Limpopo, which spends 2,800. Now, this is quite difficult to interpret because it's to a large extent factored by the service delivery configuration of each province. We know that Gauteng has a lot of higher level hospitals, or tertiary, regional, tertiary, and central hospitals, whereas Limpopo doesn't have that. So they rely a lot on district hospitals. So that's why they are significantly higher there. But if you look at primary health care, which is on the next slide. So primary health care per capita, which excludes the district hospital. You see that there's a little bit more of an alignment between the provinces. And you see that Limpopo is actually at the bottom here. So when you take out the district hospitals, Limpopo is actually at the bottom, and KwaZulu-Natal is the highest. The average is about 1,400 Rand per capita. Going to the next slide. So that's the same figure that I showed in the previous slide. This shows the same indicator, but per district. So it's probably quite difficult to see the individual district, but the point here is that you see some convergence at the provincial level, but if you look at the district level, there's a massive difference between the highest funded district per capita and the lowest. So the highest one is Namakwa in Northern Cape, where they spend 2,700 Rand per capita, and Vembe district in Limpopo, 1,043 Rand per capita. So there's some explanations, and some explanations could be warranted. So for example, Namakwa is a very scarcely populated district, so it's just more expensive to deliver services in those kind of settings. But still, I don't think that completely negates the fact that there is such a wide spread between the lowest and the highest funded districts. We can move to the next slide. So this one divides the primary healthcare spending by the primary healthcare headcount, so the number of visits. So it shows how much is spent per visit. Again, you see here over time, this is for the entire country, it has increased quite significantly. It spiked during COVID and then has declined somewhat, but even if you would remove these kind of anomalies here, you see that there's still a linear increase. So in total, if you compare 23-24 to 2015-16, there's about a 40% increase. So it tells you that there is some scope for improving efficiency in how we use our money, given that we spend more per visit now than what we did about 8 years ago. And this shows the same indicator, but per province. Again, you see quite considerable differences. So Limpopo spends about 600 per visit. Gauteng is over 800 per visit. So it just suggests that there is a lot of inefficiencies that can be addressed within the system, looking at how much we deliver in terms of services, apologies, for what we spend. We can move to the next slide. So this just shows how district health services is currently funded. So there's two main funding streams that fund district health services, and a lot of you would be familiar with this, but about 75% is funded by provincial equitable share, which is unconditional transfers from the national treasury to provincial treasuries, and they can decide how they allocate that. So part of that would go to education, part of that would go to health. Health is the second largest recipient of this funding after education. So that funds about 75% of district health services. 25% is funded by conditional grants, and that's mainly the district health programs grant, which is mainly, so the largest share of that grant is the HIV/AIDS component. So this used to be the comprehensive HIV/AIDS grant, but that's been combined with some other allocations to form this new district health programs grant a few years ago. So that is allocated about 25 billion per year. And the other component within that grant is the district health component, which funds mainly community health workers, HPV vaccinations, and various malaria interventions. So that's about 3.5 billion per annum. So just summarizing kind of the challenges that is identified from the previous slides. So obviously the first one, funding constraints are real. We're aware of that, but that has its explanations in what Rashad presented earlier, that there is just the spending path that government was on was just unsustainable in relation to the revenue that was collected. But it is a real challenge for the sector, of course, the fact that spending per capita has decreased in recent years. Fragmentation of funding, which was on the second last slide. So the fact that we have a fragmentation between the district health programs grant, the HIV component of that, the various smaller components within the district health components, and the provincial equitable share, and there's rigidities between how you can spend those various allocations. Geographical funding inequities, what I showed about spending per capita across different districts, there's large inequities between provinces, but even more so between districts. And the fact that growing unit costs, so how much we spend per visit, is still increasing. And there is quite large differences between the districts in that regard as well. And then the last slide. So some potential solutions, and I'm guessing we're going to get into this in the discussion as well, but obviously prioritizing primary healthcare within provincial budgets is something that most of us can agree to. There are several options to address this fragmentation that I showed in the slide, whether we should phase out this grant to have one pool that funds all of primary healthcare, whether you do that by having one conditional grant focusing on primary healthcare, or whether you allocate the whole envelope through the equitable share, or some other compromise solution could be considered. And then in terms of addressing the inequities, I think we need more data-driven approaches to align the allocations to need. Because a lot of these are these allocations that we've seen, and the reason why they're so inequitable is that, budgeting is just incremental, that whatever is spent last year is what you get this year. And if get a 5% decrease in the next year, then that 5% decrease applies to all districts equally. So if the inequities were there from the beginning, then they will remain there. So we need to have more data-driven approaches to make sure that the funding that we have available is allocated to where it's needed the most. And then, there's a lot of things that can be said about inefficiencies in the sector. But there's various things that can be done to improve how we spend the money just at a service delivery level. Thank you. I believe that was my last slide.
Thank you very much, Jonathan, for that presentation. We are going to then move to the second aspect of the program, where we are going to facilitate sort of like an interactive panel discussion between the two presentations. As you have seen, we have less money, but we need to then reprioritize how we're going to spend the money. And I think some of the questions Jonathan has been able to speak to, but we will have an opportunity for the audience as well, and on also those who are online to be able to also ask their questions. But I will first start with facilitating questions, and then we will open it also for the audience. What I would like is for us to really have an interactive discussion, because this is the money that we are looking at, and how can we improve the efficiencies, looking at the debt that we are in, and how can we ensure that the amount of revenue that we do collect will be directed to primary health care, which the first session was able to illustrate that is where the money is required, and how we are going to ensure that is happening. So I will invite the two panelists to please join me. And then those online, please, we will take questions in between. I feel like I'm a financial consultant today with the 420 billion that I saw. Okay, let me just, as the first question, just open up to our panelists to just respond. I think some of the questions were answered in the presentation, but I think it's always for us to expand on what has been described. So the first question was, maybe I would, to both of you, to just say, we are seeing that the South Africa has a rising health need. It's quite clear from the cancer presentation, from the Cape Town presentation on the community aspect, and also from the first presentation. And then we are seeing the decline of external funding. And I was actually surprised when Jonathan showed the amount of money that has been allocated, because from the budget speech, we were told that there's an increase in the HIV funding, which is going to be able to ensure that that decrease in the external funding will be sufficient for the health needs of the country. And then we also have the fragmented disease-specific financing landscape, evident by the cancer and the NCDs, which do not have any ring-and-fast funding. So from your perspective, what is the most urgent financing shifts that we need to move the system towards an integrated district health, primary healthcare model? And I think if you can also expand in your presentation, you showed that there was more finances spent on the district health system, which I couldn't grapple my mind than at the tertiary level, because I thought that was the most expensive form of financing. I mean, of delivering the healthcare system. But what would be the shift that will be required for us to be able to ensure that the district health, primary health care is adequately financed?
There we go. All right. Thank you very much for that question. I think maybe just to first address the balance between district health services and other hospitals. So you are completely right in that the cost at higher levels of care is much higher. So the cost per patient is much higher at higher level hospitals, whether that's regional, tertiary, or central hospitals, is much higher. But because at the primary healthcare level, you see so many more patients. That's why the total spending, and that also includes the district hospitals, by the way. So the lower level of care that you look at, the higher the volume of patients. So spending per patient is more expensive at higher level. But I think in terms of the main thrust of the question, I think the most urgent financing shift would be to look at how do we integrate these funding streams, because the way we have, vertical pots of funding, one for HIV and TB, one for HPV vaccinations, one for community health workers, one for malaria, it creates rigidities in the system. And if you say you have savings in one pot of funding, it becomes difficult to shift that money to where it's the most needed. And in any case, at the service delivery level, these services are to a large extent already integrated. I mean, if you're a nurse working in a facility, you're generally not, I mean, there might be exceptions to this, but generally you don't just treat HIV patients, you treat patients regardless of what they're there for. So because services are largely integrated, it would make sense to also integrate those funding streams. And I showed a few examples on the slide, things that we've been discussing internally within Treasury. We have raised it with the Department of Health as well, because they're obviously critical to this. We wouldn't just change anything without their consent. But we have been thinking about this kind of integration for quite some time. I mean, the HIV grant, when I joined the National Treasury in 2012, the HIV grant was about 9 billion rand. And as you saw now, it's 26 billion rand. And if you compare the HIV program in provincial departments of health, it's bigger than the clinic program, whereas the services are rendered at the clinic. So I think we need to find different ways or some way to move towards integration, whether that is through moving the funding to the unconditional portion, the provincially equitable share. That's one option. There's pros and cons of that. There's some risks with that. And when we initially pitched this to the Department of Health as well as to provinces, there was a bit of anxiety about, what would happen to HIV services if you remove the ring fencing. Would you end up with stockouts? Would you, have problems with HIV services? But I think with time, I think that is the direction that we need to move. But obviously, when you do that, you need to maintain some kind of accountability structure. So another way to do that would be to, instead of moving the money to provincially equitable share, to do the shift in the other direction. So to have a primary healthcare conditional grant, which is transferred from the National Department of Health to provincial health departments. There's pros and cons of that as well, because it might provinces might not be happy with that because it restricts how they can manage their own budget. There might be some constitutional challenges with that because there's some provisions about equitable share in the constitution. But I think we're at the early part of that discussion, and I think it's something that we need to kind of weigh the different pros and cons of whichever route we take, and obviously in discussion with the Department of Health.
Maybe just as a follow-up question, and then I'll open up for more, is that if we started at 9 billion and was sitting at an estimated of 7.1 million patients, and we are now sitting at 26 billion, is it justifiable for us to continue, maybe to re-look at that conditional grant to say, are we focusing on just the essentials and your medicines, which are your biggest cost drivers, together with your NHLS, and then you move the HR, which is also a cost driver, but get it into the PHC conditional grant, so that you are able to maintain the integrity of the HIV TB response with regards to medication and lab services. But then, because some of the HR are not even some, they are all working within a primary healthcare system, because we already have an integrated care model that we are implementing within the primary healthcare system. So I think it's something, I'm not sure what National Department of Health was thinking about, but it would make sense for me if we could move it and just reinforce the biggest cost drivers, because the rest are already in the primary healthcare system.
Yeah, no, I think that's another option that we could consider. It's kind of a compromise solution. It's kind of protecting the most critical aspects of the HIV funding, such as the ARV drugs, other commodities like PrEP, lab tests. Whereas human resources, as I said earlier, you typically don't, or not anymore at least, in the main have HIV nurses. You will have nurses that treat you regardless. So why would you have some nurses paid from the HIV grants and others from the equitable share? So I think that's definitely kind of a middle ground solution that could be considered. Yeah.
Thank you. We've got 2 questions online. Can I start with those before I move to the? So can we have Salome has a hand up? Can you come through?
Yes, thank you, John. Thank you, Jonathan, for that input. Just the comment, in terms of realities at a primary healthcare level, specifically when we start referring to cancer care and the fact that cancer care is not integrated, is actually different from what is actually said on paper in terms of integration of services. We do know that it is not happening, particularly at a primary healthcare level. So, I mean, there's an obviously, from a cancer perspective and an NCD perspective, I think there's lots of discussions that we still need to have. Also, ensuring that we have that integrated budgeting system as well. Thank you.
Thank you very much, Salome. I think your point is well taken, because these are all patients. I don't come in with a cap that I'm HIV or I'm a cancer patient when I go and seek services at primary healthcare. So we need to ensure that, like I've said, the policies are there, but then the financing, and I think the challenge is that the equitable share is supposed to be taking care of the cancer patients and the NCD patients. And this ring-fenced of the conditional grant was based on the emergency of HIV. But now that we are we've come out of the emergency, if we all agree, except for TB, I think they are still somewhere they haven't really come out. But for us to find a synergy of how and I think getting the PHC grant and being able to ensure that those particular diseases that we are speaking to will be accommodated at primary healthcare level, because it becomes diluted and it gives a different perspective if I come and seek services and there are not enough funds for managing diseases like cancer, which then need to go to the tertiary level. Can I take from the floor? You have another mic, or you need mic?
No, we're gonna move the mics between. Can I move your mic up?
Okay.
I'm gonna get
Can we allow? Can we take all three, or is it three? 1, 2, 3.
Yeah.
4.
There's 6.
Okay, let's start with 3.
So the first thing I saw was what's it called?
That's done.
And then I'm gonna go to you, and then
Thank you very much, and it's really good to hear about the thinking that's happening in integration, because I mean that's absolutely, I mean, how we function in the coalface is integrated, as you've said, and it's always been strange. And in fact, I think we'd be in a much better place in terms of NCDs in this country if we'd used the same model for NCDs that we've used for HIV/AIDS in terms of how that NCDs are managed and care is delivered, et cetera, et cetera. But what I want to talk to is the district hospitals. And I think a major issue is the district hospitals being run as separate entities and actually not part of districts, well, actually part of sub-districts, which is where they should be at. And if the district hospital was your nidus for driving care in the district and the nidus for community-based support and all that sort of things, then you are taking out a whole lot of duplication, and you're ensuring that your resources in the district hospital are made available in the sub-district. And that's something that didn't happen. There was that whole separation as we formed the so-called district health service. I say so-called because I don't think we have a district health service, because district health services are supposed to go with devolution of finances and responsibility, which hasn't actually happened. But I mean, that's another whole discussion. But that separation has actually been unhelpful because of so much efficiency and resources that could have been saved. That was done because of the fear of the fact that we know that hospitals consume resources. But if management is actually responsible for the whole sub-district and not just for the district hospital, then you actually deal with that and you put the governance in place. So that's a huge issue. I mean, there's also issues of many places like in the Eastern Cape where their district hospitals are too close to each other, and we're running 2 district hospitals for, one area. And I used to work in the Northwest, and you'd have the old Bophuthatswana Hospital and the old, Transvaal Hospital within 5 kilometers, and no politician would make the decision to close one of them, which is just, but those kind of hard decisions are needed. But anyway, it's mainly the fact that district hospital should be the nidus for care for a sub-district.
Sure. Thanks so much also for the presentations. My name is Mahfouz. I'm from Equal Education, so I have maybe a slightly different lens also coming here. But first, just on the credibility of the fiscal framework and the projections, I know Treasury did say there's a downside risk that could be caused by global instability, and we have this low inflation target. We opened today's session thinking about the people at war. So, yeah, I just want to know how much that might affect future projections, but also then thinking about the costs of not funding things like healthcare, education further on, and what sort of debt that creates, right? Because that's not in Treasury's official debt, but to what extent does it factor into these decisions? And yeah, what's the cost of non-provision like, or going to impact on us 20 years down the line? I'm working with school students, and then yeah, also just similar to that is like, from what I understand, we're cutting expenditure and trying to achieve these surpluses because the thinking is that a smaller state, or the way it's being done is that a smaller state is going to stop crowding out private investment, and that's going to help grow the economy, and thereby we get greater revenue. And if that's correct, like, it's very worrying because we know the expenses that we owe on social expenditure, particularly, and what does a permanently smaller state mean? And then just on schools, and I've learned a lot today about how the healthcare system is so fragmented, and then there's healthcare services to some degree housed in other departments like education, where there should be screening support and part of this integrated district model. But how and to what extent is Treasury involved there, or how does that coordination work? Because schools don't have access to educational psychologists, social workers, people, and other people who can help to screening for dentists, things like that. And so just, yeah, maybe some comments there.
Thank you. I'm Dr. Patingasa Pioche. I'm with the Diabetes Alliance. Interesting conversation, and don't really know where to start, but I will try. The presentation that Salome, the brilliant presentation that Salome made, could have made the same case for diabetes. I think one of the first things that struck me when I saw the budget last week, it's really in terms of prioritization. What leads the decisions that are made? We just now even heard, even in depth, that even when the money is sent to the provinces, there's still that ring fencing for HIV. And I like the point that our moderator made. We were responding to a crisis that occurred how many years ago? 20 years ago, but we are keeping the same patterns, even though the data is telling us different things. The only thing that we can rely on is StatSA output. StatSA is clear that NCDs have surpassed communicable diseases already 10 years ago. And now we have diabetes, that is the leading cause of death, already about the 5 recent years. But still, we see that ring fencing. And I heard the question that Jonathan said. He said there's a sense where people say, what will happen to HIV services if we remove the ring fencing? It's what is happening with diabetes that will happen. And then in the presentation, it was shown that most of the money is going towards hospitals or district hospitals. Do we have data to identify where is actually that money being spent? I won't be surprised that it's spent in amputations, it's spent on dialysis, it spends on people having those ailments. That is not improving their health. In the contrary, we are just basically accompanying to a premature death. We heard from a colleague in Cape Town who said that if you are 40 years old, living with diabetes and in need of dialysis, they don't even put you on the list. 40 years old. So therefore, I appreciate the work that Treasury is doing. I'm sure the circumstances are difficult, but the colleague said something. What is the cost down the line of not doing something now? There's a study that said that the cost of diabetes is projected to be 35 billion rand by 2030. We don't know how much it is there. The number of people with diabetes is about 5 million, 5.6. It depends on where you get your data. We have a huge problem, and the budget is not speaking to it. The allocation of money is not speaking to it. In HIV, we have I want to disclose that, to disclaim, that is a bit of a challenge as a public health practitioner to feel like I'm a brother fighting with a sister in terms of my father need to give me money, meanwhile he also need to give money to the sister. Like this challenge of sometimes referring to HIV, it shouldn't happen. But unfortunately, as advocates, we sometimes have to use those figures. In HIV, the target is the 95, 95, 95. Almost met across the board. In diabetes, in 2022, the Department of Health came up with the 1960-50. No baseline, no capacity of tracking it because there's no systems. In the Department of Health, NCD department is maybe 4 or 5 people for the whole of NCD in the whole of the country. In the provinces, you have usually 1 NCD manager per provinces. How are they going to respond to such complex diseases? Diabetes is so different from cancer, which is so different from epilepsy, so different from mental health, but it's one person who is supposed to look after those things. And if there is no money, if there is no ring-fence money to push them to employ more people, we're going to still have the same issue. And with all due respect, complication of HIV can be solved with a tablet. These are infections. Complications of diabetes or of cancer or those kind of complications, these are spent in theater blocks and dialysis rooms. It's a lot of money. So I really personally don't understand, and I would like maybe Jonathan to assist us. How was the decision made to still ring-fence 26 billion for HIV, which is meeting the target at 95, but being quiet about NCDs and missing the opportunity to increase excise taxes on, for example, sugary drinks and tobacco? Thank you very much.
You can proceed, then we'll take the next round. Thank you very much.
Okay, thank you there. Thank you for the questions. We're learning a lot just through the questions. One is the credibility of the outlook. Yeah, Mahfouz, you're right. Any outlook is as good as the assumptions, and the assumptions are about the uncertain future. And we saw with the unprovoked bombing last week that the future is radically uncertain, and who knows what happens this week. So the implication of that in the context of health financing is not good, right? If debt doesn't stabilize or Treasury's assumptions are not realized and the outcome is actually worse, then there's fewer resources available. And that's why this conversation is quite critical, is in the context of there not being significantly additional resources available for the next 7 or 8 years. How does the health system and how does health financing and the configuration of health system, we've been talking about further integration, allow for more resilience? I think that's quite important. And then also what measures are taken to reduce, preventative as opposed to treating. Your question about the state and the revenue outlook and the logic on whether lower debt drives higher investment and therefore higher revenue. I think the idea of crowding out is strongly contested now, even in mainstream economics. But I don't think that's the critical point over here. The critical point over here is that reducing debt accumulation creates resources. That's just the reality. And it is an important objective when you're spending 460 billion rands a year servicing that debt. So creating resources is important. That said, though, and as you pointed out, if we're not meeting our obligations on health and social development, on policing, on education, it does create additional concerns going forward. But I do think it's hard to argue that the business as usual model in terms of how health is delivered, how education is delivered, how policing is delivered is not purely a resource issue. It's also the way resources are allocated and how services are delivered. You made the point about the inflation target, absolutely, and this hasn't come up in my presentation given the shortage of time. HELP also faces the challenge because of the Reserve Bank decision, which then was ratified by the Treasury last year to move the country to a lower inflation target. We've seen reductions in the nominal allocation for health, education, basic education. The concern over here, and as health individuals sitting in the room understand, health inflation isn't going to stick to 3%. A lot of it is imported. If your vaccines are coming from abroad, if your pharmaceuticals are coming from abroad, if your machinery is coming from abroad, it's not going to respond to whatever Lesetja Kganyago says the inflation target is, right? So you're going to see further squeezing out of resources available, or potentially see further squeezing out of resources available for health. Okay, so that's on Mahfouz's question. We've been talking about conditional grants for some time, and I'm not sure if it's the appropriate forum to say this. And whilst resources are constrained, the allocation and use of resources is, as much of a problem. I mean, I have an intimate working relationship from work I did last year with one of the provincial health departments, and the individual sitting one beneath the CFO mentioned to me, and this is in response to PEPFAR, that we don't have a funding issue, but we use a significant share, and Jonathan may not want to hear this, but they use a significant share of the conditional grant to pay liabilities, right, to pay your accruals. Now, it was an honest conversation. I won't disclose which department. He mentioned to me that we don't have a resourcing issue, right? And so funding happens. And so maybe the issue isn't primarily about the quantum of resources. And I'm not saying it isn't a problem, but it is amongst other problems. And so integration matters, how we treat matters, our use of sin taxes or excise duties, excise taxes actually does matter in terms of reducing incidents. So thanks again, and I think I've covered the points that consider my part.
Well, thank you very much for excellent comments and questions. I think from the colleague from Equal Education, to the extent to which we kind of consider treatment debt or service debt or however you wanna frame it, we do definitely. I think the first budget after the COVID in 2021, there was massive cuts across all sectors. Because of the collapse of the economy at the time and just revenue projections plummeted and what my colleague spoke about earlier, that Minister Mboweni spoke about, the gap of the hippo, the mouth of the hippo that needed to be closed. So there were massive cuts, including in the health sector. Since then, we have analyzed the potential consequence of this. Not that we were oblivious to it from the beginning, but we obviously needed to look what are the consequences or impact on services of this trajectory. And in each subsequent budget since then, we have allocated money back to the health sector, and I think to some extent as well, or to education, although I'm not so familiar with education budget. But in each budget since budget 2021, we have allocated money back to the sector. So there is at least some degree of stabilization, and we have to kind of balance the two objectives of resourcing the sectors appropriately, but also realizing the economic and fiscal environment we are in. So we're trying to strike a balance between the two. In terms of school health and the role of National Treasury, so the more granular in terms of the budget allocations you look at, the kind of the less role of the National Treasury. So the more granular look at funding for very specific intervention, most of that happens within the health sector itself. It's where you have these, like the HIV conditional grant, or we have an infrastructure grant, where we have these conditional grants. That's where Treasury's role becomes a little bit more pronounced. So in terms of school health, fairly limited. We've had some discussions. There was a GIZ funded project. I don't know if you're familiar with that, where they tried to, at a district level, facilitate some improved coordination between the health sector and the education sector and Treasury, and I think maybe social development. So there are some, at lower level, there are some efforts to strengthen that coordination. But the National Treasury's role is fairly limited. So the HPV vaccination program, which is funded through a conditional grant and implemented through the school health program, that's somewhere where we play a little bit more of a role in terms of budget allocations and monitoring. Sorry, my screen where I took my notes just froze. I need to just unlock it quickly. But while I try to do that, so the colleague from the Diabetes Alliance, I think made quite a few important points, and it ties back also to what the moderator talked about, how HIV, when the grant was conceptualized and introduced, it was really at an emergency type of environment where you had to make massive additional allocations to fund the rollout of the ART program, prevention efforts, etc. And as those programs have matured and we don't implement it through these standalone kind of structures anymore, we need to look at integration, and that's what the point that I made earlier, but also other colleagues in the room have made. And I think, you know, the fact that we do ring fence 26 billion a year for this, whereas we know that there's so many needs in other areas, I think that's something we definitely need to look at. So, I mean, even the suggestion we talked about whether we should ring fence ARVs, for example, there might be good reasons for that, but then should we also ring fence hypertension medicine? Should we ring fence whatever costs are involved in diabetes programs as well? We don't. You asked as well. Do we know how the budgets of the district hospitals are spent? And specifically, you made the examples of what interventions are funded. We don't have that data. We can analyze data in terms of how much is spent within each hospital on compensation of employees, on drugs, on goods and services. But we don't have data to analyze per condition or per intervention. It's just not something that's available in the financial system. Not to say that it's not important, it's just that at the moment the data is not there. Yeah, and I think, sorry, one more point about the integration. I think, you know, this verticalization of HIV programs is not only at the provincial level. If you look at, it has effects across the system. I'm guessing if you would compare the number of people in the National Department of Health that work on HIV and compare it to the number of people working on NCDs or specific diseases like diabetes or hypertension or whatever it might be, I don't know the number, but I imagine that the ratio is quite significant. Whereas, as you say, with HIV, we have, you know, quite clear intervention. We know what needs to be done, whereas NCDs is much more difficult to come up with clear-cut solutions. And those solutions might not necessarily be in the health sector. Part of it is, but there's obviously important interventions that need to happen outside the health sector as well. Thanks.
Thank you. I think I just want to speak to the diabetes NCDs and to say there has been a shift from national department. I mean, I attended one meeting where they are looking at integration, but obviously integration should be followed by the resources. Because if we are integrating and bringing district health managers, TB, HIV, NCDs, we need to make sure that the resources are allocated. And I think that is something that they are trying to work on. And in response to your question to say, where is the money spent? I think from an NCD data collection, if we were to emulate what HIV and TB has done, the data collecting system for NCDs is also not very poor. As a result, even if you go to National Treasury and try and motivate for funds, you don't have the data to say it. Whereas HIV is able to say, these are the number of patients that we have on treatment. The data systems are also letting us down. So it's something that we also need to advocate for, as we want the resources to follow the emerging diseases, the data systems in collecting. And I think the Cancer Association also said, I mean, with the cancer registration, they only have what is pathological. So the data systems need to be improved. That is how HIV got it right and TB. But because of the reinvest funding that is there. So for us to be able to get there, we need to also reinvest and make sure that the data is able to speak to what the needs are at a primary healthcare or at a district healthcare. Otherwise, we'll always be speaking on anecdotal evidence. We all know the complications that we see. The Cancer Association knows, but your data is not telling us what we want, what the motivation that needs to go to National Treasury, and so that we can reinvest the budget for the primary healthcare. Can we then take the last round before I ask my next question? I think it It was, she has gone out. Yeah. With you.
Do you want it? Yes. Okay, sure. I'll have
I think it was one hand.
one hand away. Okay. Okay, start.
Yeah.
Where?
Yeah.
Oh, sure.
Thank you. So yeah, thank you to the guys from Treasury giving us this information on how the budgets are structured and where the money is going. And I understand that as Treasury, you may not have the power to direct that. You can report on what it is. The extent to which you sell the story about where the problem is, whether it's corruption or whether it's a will to actually do the right thing and spend the money in the right place is outside of your ambit to influence. But in the way that you influence the narrative, here we had a discussion about financing, and I think the integration bit comes out quite strongly. And you do support that in saying that we need to look at these budgets in a different way and understand holistically what is the problem in poorer households and the health of people. And so the integration will go some way towards that. In the input I was making, I was driving an agenda of understanding and supporting community health systems. And so in this approach, the district and what's going on in the hospitals, I understand, and yes, it's important. But it's that link between the hospital and the household and the work that gets done in that space. And I'm not getting a sense of an understanding of the decision makers, the people allocating the budgets, the importance attributed to that work and the difference investing in that work will make. And I'm hoping that from your attendance here, you get an appreciation for if you were to reconceptualize what's the best investment to improve people's health, community work, and the work that is the link between the district hospitals and the poorer households. So the question to you then is, what further research and what analysis do you think will help make that conceptual shift so that on the prevention side, the data is there and you believe the story? We must put money into prevention. That's how we'll solve the problem. On the integration, we must put money and hold that, whether it's a governance problem at a local level or we must do that. But this conceptual shift that is needed to support community health systems, and I outlined in detail what they were in the last slide. What kind of research and evidence do you guys in Treasury need so that we can see an improvement in the spending at the community level to support those community health systems? Thank you.
Is there another question? Oh, yes, second one. And then the third one is online.
Okay.
They can respond to all.
No, thank you. I'm coming back because I was reminded of something about the health promotion levy that we are talking about. As the Diabetes Alliance, we've been having a summit, Diabetes Summit, starting in 2021, 2023, and then 2025. Since 2023, we've tried to get Treasury to come and talk to us about, obviously, how can we fund money to fund some of the diabetes programs. Now there's this opportunity with the health promotion levy. A former director at the Department of Health, NCD department, told us that what comes back in terms of money from the health promotion levy that goes back into health programs or Department of Health is less than 0.1%. So we call something health promotion levy, but is it really going towards promoting health once it's collected? So obviously having the opportunity to have Jonathan here, can we understand more about that? Is the money collected to go because of going back to for the sake of going back to the health programs, and I would assume maybe NCD included, or is it the full story is that the lady told us that whatever was allocated previously, they actually failed to actually spend it. But there is an appetite from Treasury to increase the allocation. So as an advocacy body, I'm sure colleagues are also interested in understanding that mechanism and what can we do as a civil society organization to maybe ensure that from Parliament there is a clear mandate that the money that is collected through the health promotion levy goes towards promoting health and financing health programs. Thank you.
And lastly, online, let me take your last question.
Thank you very much. It's more a comment than a question. First of all, I would like to make the correction. We are speaking as the Cancer Alliance. The Cancer Association is a member of the Cancer Alliance. Cancer Alliance is a collaboration of more than 30 cancer organizations in this country. So I just want to make that distinction very prominently, because we are the only body that does mainly for our members do advocacy for cancer. Just in terms of the health promotion levy, the point that was raised by the last speaker there, the latest expenditure, or let me say the latest allocation of the health promotion levy for the budget year that is coming to an end now, only 15 million rand, 15 million rand of the allocated budget in terms of the health promotion levy has been allocated, and only to, I think, less than 5 projects. Now that in itself becomes a serious issue when we do not have, first of all, insight from an advocacy perspective or civil society perspective in terms of how the money is allocated and also how it is spent. So if it was not for the call to proposals, or for proposals from the Department of Health, to which many organizations, and I know the last speaker and many of our own members of the Cancer Alliance actually applied for that funding, we've heard nothing from the department. And there's been no clear communication, there's no guidelines in terms of how the health promotion levy is going to be spent. And that is the kind of, I want to say, oversight that we need to start looking at from a civil society perspective, that if we that are literally maintaining certain services on behalf of the Department of Health, that we should be involved in making decisions. And I think that is a very important aspect that is missed sometimes when we start talking about the expenditure of health promotion levy, or the sugar tax, or the sin tax, or whatever we're going to call it. So we really need to start looking at that pot of money and what will be the involvement of civil society in terms of making sure that the money is spent on the right things. Thank you.
Thank you. You can respond.
So most of the questions are for Jonathan, so I'll just handle one or two. I'm former Treasury, so I can say certain things which he can't say. So it makes sense. So I thought I'll go first to make his life a little bit easier.
Yeah.
So health policy isn't set by Treasury. I think it's very important to know that. It's set by the Department of Health. Treasury executes in certain respects. I'm going to talk specifically about the health promotion levy. Treasury's approach, and this is almost universal, is there's no earmarking of taxes, right? So something comes in, the objective of a cigarette tax or tax on tobacco or alcohol or the health promotion levy has two rationales. One is you want to discourage behavior which is harmful to society, or at the very least, internalize the cost, right? That's the externality. So there's a cost to society from the consumption of alcohol, sugar, and tobacco, and we as society, or certainly the public purse, has to fund the implications through gender-based violence, through healthcare, through the courts, through policing, and through lost productivity. And so that's part of the rationale. So part of the rationale is to discourage the consumption of it, but secondly to internalize the costs, so to reclaim some of that, right? We don't, I mean, the WHO has certain guidelines or certain on terms of the final price for tobacco that needs to go through taxation as well as alcohol. We haven't reached that yet. We progressively trying to realize it. We were far ahead of the curve on tobacco in the 2000s, and we've lagged a bit in terms of increases relative to inflation. But I don't think it's a viable conversation as a non-treasury person to say, hey, we need to earmark that tax and spend it directly. We can discuss what's happening, whether there's funding happening, where there's resources that are raised through taxation on alcohol consumption are going in that direction. I think it's a useful exercise to see what share of the health promotion levy is going towards treating diabetes and prevention of diabetes and the like and associated challenges. So I think I'll leave it at that.
Thank you.
No, thank you very much. Yeah, I think I'm largely covered on the health promotion levy. I think so. Yes, the principle is that taxes in very exceptional circumstances there is ring fence of taxes. So levies like the UIF, a portion of the road accident of the fuel level is ring fenced for the road accident fund. But generally, regardless of the type of tax, it goes to the general pool. What happened was when the health promotion levy was introduced, in parallel, we also made an allocation to the National Department of Health for chronic disease prevention and health promotion. But there was no direct link to that specific revenue. So there's no sort of formal link. It was just that it was introduced in parallel. And as you pointed out, the spending on that allocation has been struggling to pick up. So we allocate at the moment about 40 million for it, and it used to be more, but because of the low spending, it has been reduced over time. I think the question on what research would be needed in terms of how to design a financing mechanism to strengthen the link between district hospitals and community services, I think it's a bit difficult to answer. So, because most of that will be managed at a provincial level, I find. I don't, or maybe I'm not understanding it enough conceptually to understand what the financing implication of that link would be, and what would be an example of a financing reform that would strengthen that link. But I think in the main it would be something that is managed at a provincial level. But I'm happy to further the discussion on it. I think maybe I didn't quite understand, the specific budgetary aspect of it.
Maybe I can assist you. So, as he has already alluded, the equitable share is what is financing PHC services currently. There's no ring-fenced budget. So under PHC, you have district health and you have primary health care clinics. But what you are speaking to is PHC re-engineering in the community, which is the ward-based outreach project. So how that is allocated really would be what they get as a funding from the equitable share to then allocate the resources to where it is needed. Unless, as we have already discussed, you have a ring-fenced budget on the PHC to then say you are demarcating this amount of money which is given to primary health care to have a portion that goes to the community aspect. I think that is the only way. Currently on the conditional grant, he has ring-fenced budget for the community health workers who are in the community. That is already ring-fenced as a payment, and what National has done is that they are no longer on a stipend; they are going to be on a salary. So you already have the headcount ring-fenced budget for primary health re-engineering. Whether that is enough, I think it's a story for us to go back to. But what other resources would you then require? Would then have to come from the equitable share, because they are the ones implementing primary health care. Unless we then move to the ring-fencing of primary health care and have designated line items to be able to then speak to whether you want to increase your head count, you want to put equipment there, because in the conditional grant, it's all line items that are there. Do you want to increase your drugs? Do you want to increase whatever you want to be able to go into the community, do the screening? That would be how it would have to be work to be put together, because currently you have the ward-based, they are ring-fenced, they are paid under the conditional grant, but they are working within a primary healthcare system which is funded by the equitable share. I hope I'm trying to clarify. I think we've come to the end. I was told the time is up. I think just to say my last comments to say, I think this has been a very fruitful discussion for all of us. I'm walking out of here knowing that I'm contributing to 460 billion debt. Debt, yes, 460 billion, which is the interest rate, yes, that we are paying through the taxes that we pay every month. And we need to increase our revenue if we want to improve our health system, but we still need to relook at what we have currently allocated to the health department on how we can be efficient, especially in the primary healthcare setting, so that we can improve the efficiencies and we have clear deliverables for both prevention, curative, and include comprehensively an integrated system where all diseases are going to be beneficial to the allocated budget. And we need to learn lessons from HIV and TB so that we can improve our data systems and be able to implement the programs and get the allocated budget. But that we are servicing a debt, and I think our question was whether we are going to ever get to the early 2000s where we are not servicing a 460 billion debt. I don't know. That is on my side.
I think they deserve a big hand.